Acute upper airway obstruction. Key points. Allow children with acute upper airway obstruction to adopt a position of their choice and avoid causing distress. Blank. In any child with severe acute upper airway obstruction, nebulized adrenaline may provide temporary relief while awaiting other definitive measures. Background. Due to their size, infants are most at risk of severe upper airway obstruction. Children with pre-existing narrowing of the upper airway may fully obstruct with otherwise minor acute upper airway swelling. Although croup is the most common cause of acute upper airway obstruction, other diagnoses must always be considered. Assessment. Allow the child to settle quietly on parent's lap in a position of their choice. Rapidly assess airway patency and respiratory status. Allow the child to settle quietly on parent's lap in a position of their choice, and observe closely with minimal examination. Mild obstruction. Able to speak or cry, may be hoarse. Intermittent stridor or minimal or no work. Intermittent stridor or occasional stridor. Minimal or no work of breathing. Good air entry. Moderate obstruction. Tachypnoea. Stridor. Prolonged inspiratory time. Moderate work of breathing, nasal flaring, grunting. Decreased air, paradoxical chest movement. Decreased air entry. Severe to complete obstruction. Hypoxia, late sign. Slow respiratory rate or marked tachypnoea. Sniffing or tripod position. Agitated or drowsy conscious state. Severe work of breathing. Markedly reduced or no air movement. Silent gagging or coughing. Total obstruction will rapidly progress to unconsciousness and cardiorespiratory arrest. Differential diagnoses. Presentations, particularly the bacterial causes, often overlap. Possible diagnosis. Blank. Features. Young child, rare and LT 3 months. Rapid onset harsh barking cough. Hoarse voice/cry. Stridor, may be febrile and miserable but systemically well. Blank. Swelling of the face and tongue. Wheeze. Urticarial rash. Allergen exposure. Hemodynamic compromise. Blank. Young child, or developmentally similar. Very sudden onset. Coughing, choking, may have very sudden coughing, choking, vomiting episode, may not be witnessed. May have unilateral chest findings, wheeze. Reduced pharyngeal tone or size. Reduced conscious state e.g. after drug or alcohol ingestion, recent. Blank. Pre-existing narrow or floppy upper airway. Retropharyngeal abscess. Sore throat. Fever. Neck pain and stiffness or torticollis. Fullness and redness of posterior pharyngeal wall, may be midline. But can be laterally behind tonsil. Dysphagia and drooling. Peritonsillar abscess. Severe sore throat, often unilateral. Hot potato/muffled voice. Trismus. Swollen posterior palate and tonsil, with medial displacement of tonsil and deviation of the uvula. Epiglottitis. Inadequate HIV immunization or immunocompromised. High fever and systemically unwell. Muffled voice. Hyperextension of neck. Dysphagia. Pooling of secretions, drooling. Absent cough. Low-pitched expiratory stridor or stridor. Bacterial tracheitis. Systemically unwell. More severe and rapidly progressive symptoms. Recent URTI. Markedly tender trachea. Cough may be productive with thick secretions. Ludwig angina, swollen, Ludwig angina, infection of the sublingual and submandibular spaces. Swollen, tender floor of mouth and under tongue. Facial laceration or dental abscess. Submandibular swelling. Airway burns. Burns elsewhere, especially facial. Singed nasal hairs. Sooty sputum. Trauma. Bruising and swelling of the neck. May progress. Subcutaneous emphysema. May progress to pneumothorax/pneumomediastinum. Management. Investigations. Children with moderate to severe upper airway obstruction are at high risk of deterioration and complete obstruction if they are upset, sedated or repositioned. Investigations should be deferred until the airway is secure. If access is required, use appropriate analgesia and distraction techniques to minimize distress. Children with X-ray do not require any investigations. X-ray, chest and/or soft tissue neck, or CT may be helpful in identifying the location and nature of upper airway obstruction. Treatment. If is required, it will be a difficult airway. Involve the most senior clinician available plus or minus anesthetic or end support. If awaiting other definitive measures, oxygen can be given. It may improve saturations but does not relieve obstruction. Consider nebulized adrenaline to provide temporary relief in any life-threatening upper airway obstruction. Consider dexamethasone 0.6 mg per kilogram IM/4/oral to reduce swelling if present. For intubation, use an endotracheal tube 1/2 to 1 size smaller than usual for age. Cuff tubes allow for cuff inflation if leak develops when obstruction begins to resolve. Gaseous induction methods are preferred. Blank, blank. Consider consultation with local pediatric team when child has moderate acute upper airway obstruction. Consider consultation with anesthetics and/or ENT. Child with severe acute upper airway obstruction. Child is at risk of deteriorating due to known difficult airway. Consider transfer when child is at risk of deteriorating and requires airway management beyond the capability of available local services. For emergency advice and pediatric or neonatal ICU transfers, see. Consider discharge when the cause for the acute upper airway obstruction has been identified and symptoms and signs of acute upper airway obstruction have resolved, or are mild and improving. Appropriate management undertaken and an adequate follow-up plan is in place.